Welcome back to the Feminium podcast. I'm your host, Jailyn Avila, and today we are diving into an essential yet often overlooked part of emergency medicine, and that is reproductive healthcare in the emergency department. I'm joined today by Dr. Morgan Bowling, a pediatric emergency medicine physician who's leading efforts to integrate reproductive healthcare protocols into the emergency department, and Dr. Sabena Vaswani, whose journey from tech to medicine has fueled her advocacy for sexual and reproductive healthcare across the globe and indigenous communities, as well as more locally at home. Together, we'll explore how emergency physicians can make a real impact, such as prescribing contraception and managing early pregnancy loss, building partnerships with our amazing OBGYN and pharmacist colleagues, building relationships with hospital leaders, things like that. This conversation is about meeting patients where they are, breaking down barriers and creating sustainable, inclusive systems of care in the emergency department. Let's get started. Hello, my name is Jailyn Avila of the Feminium podcast. I have with me two special guests. That's Morgan Bowling and Sabena Vaswani. And I basically met you guys very recently. Sabena, we've known each other for maybe a few months. We've Zoomed. Morgan, we've not met before we did our sound check a couple of weeks ago, right? Or last week? No?
Yeah.
We're fast friends, which is great. Sabena is the director of the state-based reproductive healthcare cohort here at Feminium. So she oversees all the different state-based platforms, all the state-based initiatives that we have. In New York, Presbyterian Queens, she is the Director of Global Health and Community Outreach and a clinical assistant professor at Weill Cornell College. Morgan Bowling, you are the New York Cohort Director for Feminium. You're an assistant professor of emergency medicine at the Icahn School of Medicine and an attending physician in the Department of Emergency Medicine. Am I saying that right? Is it Icahn or Icahn?
No. Perfect.
Thank you. You completed your residency in pediatrics and then a fellowship in pediatric emergency medicine in 2022 in Beth Israel Medical Center in Newark. And, West Virginia. I actually randomly know a lot of people into med school in West Virginia. I randomly know a lot of people in West Virginia, and the type of people that school produces, it's always the kindest, smartest, sweetest, funniest people. I don't know if it's just, those are the ones that emigrate out of West Virginia. And I'm just thinking scientifically, is that the people that emigrate out are a certain type of people, or is it just that school in general?
I think it's just people in West Virginia are just some of the kindest, most generous people I've ever met. They welcomed me with open arms. So I will always have a soft spot for West Virginia. Some of my best friends still live there. So
I love
that.
Yeah,
it's a beautiful place.
From what I'm understanding, it is. I went to Huntington to teach once, but 10 years ago, and everybody was amazing. Morgan.
Yeah. Yes.
Can you tell me a little bit about all the stuff you did during your fellowship training? And the reason why I think this is important is because you seem to have this internal motivation to do things. And it seems like you've done a lot of work. And I was just wondering if you could talk to us a little bit about your experience kind of in fellowship, what brought you to that, your fellowship training, why not stay in pediatrics, and then how that kind of transferred over to doing reproductive health. Sabena, we're going to hear your story as well. Please interject, please interrupt. But from a EM trained person, which you are EM trained, but I didn't do a pediatric fellowship. I'm going to be honest, and this is my ignorance. I didn't really consider a pediatric EM attending being someone who is interested in reproductive health.
I I've always been interested in reproductive health. In medical school in West Virginia, I very seriously flirted with the idea of going into OBGYN, and then for various reasons pivoted to pediatrics, which seemed like a natural pivot at the time. Did residency, as you mentioned, in Newark, which has an incredibly diverse patient population. And unfortunately, a lot of our patients struggle with low socioeconomic and issues with health literacy. So very towards the end of my residency, I was doing an extra rotation in the PEDS-ED because I was very interested in going into PEDS-EM, really because of the critical care component of it, and the procedures and things like that. We had a patient who came in very early in the morning, as our adolescents often do, and came in for a pregnancy test. And at the time, I was pretty naive, and I'm thinking to myself, why would someone come into the ER at 3 a.m. for something that you can buy at the dollar store? Like, this seems, there's something more to the story. Well, lo and behold, she knew she was pregnant. She had taken multiple pregnancy tests at home. And I think, to this day, I'm not really exactly sure what she was looking for from us in that moment. But we, of course, confirmed her pregnancy. And of course, my PEM attending grabbed the ultrasound and put the probe on her belly. She was pregnant with twins.
Oh, wow.
Even to the very untrained eye, as a third-year peds resident, kind of see the two kind of very clear circles on this gray and white fuzzy screen, and you're like, wait a second. And even our patient, who was 17, realized it was twins. I mean, it was very obvious. Come to find out, she had a 10-month-old at home.
Oh my
And
goodness.
again, the very naive third-year peds resident in me is thinking to myself, how could this have happened? Does she want this? Did anyone ask her? She just delivered 10 months ago. And again, I don't have children, but there's, you deliver in the hospital. I imagine there's post-op care. Like, has anyone talked to her about contraception, about her options, about family planning? And right then and there, it sparked this confusion, frustration, questions of what are we doing, what's going on, and really, like you alluded to, the essential role that the pediatric ER plays in women's health. And here we are, many years later.
That's such, oh my goodness, that's such a powerful story, because I had my first kid in residency, and it was really difficult. And we don't need to go into what her like home life was, right? But obviously there's a component of it if she's 17, and now she's gonna have 3 kids at 17. There was this really powerful quote that I actually wrote down that you said, and you said, "I just don't want our young patients to be forgotten." And it's a demographic that full disclosure, prior to talking with you about it, that kids get pregnant, right? Everybody knows that. It's not good. Well, I'll take that back. I'll say it's not ideal with what I believe is like good for the parents, good for the kids. But that makes it so much more important to be aware of it. And especially with we'll say everything that's going on. I anticipate that this is going to become an even bigger problem. And you're so right. We can't forget about our younger patients.
No.
Oh,
No.
my goodness.
They often, they're so vulnerable to begin with, right? And we always hear about these, adolescents, whether it's, sickle cell patients or, congenital cardiac patients falling through the cracks, right? Mm-hmm. Who follows them? Do they still see their pediatrician? Do they transition to adult care? It's often so challenging. I mean, I'm sure Sabena sees this every day at work to get outpatient follow-up for your adult patients, and then when you're trying to initiate that care for an adolescent. So I feel like this reproductive health subset, this group of patients is just incredibly vulnerable. And exactly right, we can't ignore kind of what is happening in the world and the consequences that's going to have on our youngest patients.
Sabena, what about you? How did you get into reproductive health?
Yeah. So Morgan and I have this in common in that we're both not necessarily career changers, but career transitioners. I started my career off in tech for 5 years before I entered medicine. Had no one in my family even, really exposed to healthcare at all. And when I was living I was living in Brooklyn, but I was working in Manhattan at the time in tech, and I used to volunteer on Saturday mornings at Planned Parenthood. And initially it was like, oh, let me just, get some volunteer hours in. And it was such a bad hour. I would go at 7 a.m. on Saturday morning. Like, this was my mid-20s. I should have been partying. But it was part of my joy of the week because I was specifically working in the recovery room. So women after, MUAs would go there, and we would have them just kind of like sit. We'd obs them for a little bit, make sure that they didn't have heavy bleeding. And then I was like a therapy dog in a way, just being like, do you need some water? You want some ginger ale? You want a hot pack? Do you want to chat? Do you want a hug? And I just feel like that intimacy that I feel like I got to connect with my patients was something I never really could forget. And exactly like Morgan, went to medical school thinking I was going to do OB-GYN and then fell in love with emergency medicine. It felt like my people, my place. And one of the biggest things that actually drove me into medicine was wanting to do international work and wanting to do global health work specifically. That's why I did my fellowship in global EM. And I would say like where Feminem sort of started folding into my life was during fellowship. I kind of made it my specialty to do SR, like sexual reproductive health work. And my life mission was really to advance sexual reproductive healthcare in India. I'm like, this is what I'm going to spend the rest of my life doing. Especially like I'm first generation American, second generation Indian. I'm like, okay, this is going to be my calling. And started volunteering with an NGO, or I worked with an NGO out there, and I think it was eye-opening for me, especially I did med school in the Midwest too, in Ohio, that I started to realize that some of these access issues with, getting sexual reproductive health care was often more difficult in the United States than in India. And I'm not going to say that's like a broad stroke for every single person. I know every situation is going to be different, but I started to feel like, wow, I have had this, not necessarily backwards, but I've had this confused, where I was like, oh, America is such a woke place. I work in New York City. I'm from California. I, have all these options, like I have legal backing and all these sorts of things. And I started to feel like, wait, am I really even giving my patients proper contraceptive counseling? I've had so many patients come to me being like, I don't have a desired pregnancy, can you help me? And I often discharge them without having the ability to prescribe the medications that I feel like, we should have within our scope. And so then I think that's when Feminem started to fold into my life a little bit more, where I was like, okay, how can I have a little bit more of a domestic footprint? Knowing that I still love this work internationally, but we don't even have our stuff figured out at home. And this is what is my touch point every single day. I also work in the reservations in New Mexico, and I feel like that's also been like a huge, gap in care. And so, yeah, I would say those have been like the little kernels and why this work means a lot to me. And I've just been frustrated. I've been confused and frustrated. And yeah.
I also need to give a shout out to Ohio. I did my training in Tennessee and then fellowship in Kentucky. And Ohio also is phenomenal. One of my favorite, it's probably, I want to say number 4. I love traveling, and I think it's my number 4. Maybe number 3 actually place. No, number 4 I'll say is Ohio, specifically Columbus. I mean, all Ohio is great, but I love Columbus. And I also want to comment on how you used woke in a positive sense, because that's honestly how I've used it as well. Well, I do. I mean, it's almost like it's said often as like a pejorative, negative term, but the way that I mean, I'll speak for myself, and if you feel differently about it, I'll, please comment. But I feel like woke means that you are aware of social issues and you're doing what you can to address those social issues to make sure that everybody has a level playing field, such as access to reproductive health. Because we know, and I was also going to ask you about how your work in New Mexico and how, your international work in places that, like by numbers, I guess, maybe should have more problems with reproductive health care, and how you mentioned that it seems like it's informing some of your care here in the States as well.
I think like I would say, well, yes, for the woke thing, yes, I feel like they've, for some reason, it's been kind of like weaponized as like a way of calling people hypersensitive. I don't know what it is, but I do think awareness is kind of how I equate it with. I would say with respect to like the international work or the, I guess, more austere environment for, and Morgan,
Mhm.
chime in here because I know you do international work too. I think it's actually made me more aware about where some of our own shortcomings are, truthfully, where I'm like, I cannot take it for granted that someone's going to have follow up. I really can't. I think like it is the
Right.
expectation in some of those situations, like, working on the reservations, et cetera, that it's going to be harder to secure follow up. But who the heck said that we had it easy here, anyways? Like, I remember, when I was in fellowship, I used to work in the community hospital as an attending here. And I had a girl who was like, maybe she was sort of like in that peds, late up,
Mhm.
early adult phase. Like she was like 19, 20, undesired pregnancy. And she was like, it was a Saturday afternoon. She says, I have exams Monday through Friday. I need you to get me, like her mom, my mom is here. We're all informed. There's no
Wow.
secrets. Help me terminate this pregnancy. I have to go to school on
Mm.
Monday. I'm like, I can't. I'm not like allowed to give you Mifimizo. So I'm calling OB and they're like, discharge, we'll see her next week.
Oh,
Someone will call her. I chart stalked that patient for like 3 months. She never got seen in our system again. Or anywhere that
oh
touches Epic,
no.
I can say that for certain. Maybe she got care
Mm.
elsewhere. I hope she got the care that
Sure.
she chose at that point was right for her. But I think like seeing those things outside and like I guess just more again austere settings has made me just aware that every single time we discharge a patient from the emergency department, that's also a source of vulnerability, whether it's for us as a
Yeah.
physician or it's more importantly, like what does that interface for the patient? Does that mean that like even in a simple setting, I start someone on metformin, where even like that, yes, we have endocrinologists, yes, we have primary care doctors, but I'm going to not take it for granted as much. I'm going to try to define what I believe is a safe and appropriate scope, both with respect to my institution, but also with respect to my patient. I think it's kind of like that dueling thing that working in some of those environments has just reminded me that we're not working perfectly either, but it's also given me some of the confidence to maybe decide like when am I going to practice within a specific scope that I have determined is appropriate for this specific situation.
So, I mean, I think you hit on some really important things because sometimes folks ask me a lot about international work and they're like, well, why do you go to far corners of the world when you can walk outside and we're having our own crises here in New York City? And that's a valid question. And I don't always have the right answer, but I think you're absolutely right in the sense that it has so dramatically affected the way that I practice medicine here in New York City. I came back from Tanzania less than a week ago and doing some mission work there, medical mission work. And one of the focuses of our work was menstrual care. And so one of the projects that we did is we brought reusable menstrual pads to women in these very remote villages in Tanzania. And it was a wonderful thing that we did, but it really raised a lot of questions for me. Exactly what you were saying here in New York. I feel confused and frustrated because we have so much available to us here in the United States. We have, I mean, you walk into any, CVS, Duane Reade, and you can pick, whatever menstrual product works for you and is right for you. Now, of course, there's a financial constraint that a lot of people, suffer from, but yet we have so much potential. And yet, so often, we can't give comprehensive care to the young woman that's sitting in front of us at our state of the art tertiary care center. And going back to what we were saying about just being confused and frustrated, I feel like I have, like, the world is my oyster, and then yet it's so not.
Right.
And it can be
There's
very,
constraints, right? There's weird
yes.
constraints, and I imagine that it's frustrating to know what the right answer is, but be inhibited by not by laws and by rules that are actually like not grounded in reality and also not evidence-based. And I'm a very evidence-based person. When there's a topic I don't know, I obsess about it until I understand it. And I like to do things based off of what the available evidence is. For instance, a couple of nights ago, I had a patient that came in VTAC with a heart rate above 200. And she was awake, thankfully. We did the whole regular kind of pathway. We gave amio, we gave lidocaine, and we got her down. And when we talked to the cardiologist was like, oh yeah, stop the amio, put them on esmolol. You can start with some metoprolol, but then consider shifting them to esmolol. And I was like, why? And the cardiologist was like, oh, it's because it's SVT with aberrancy. And I was like, what do you mean? And so like I obsessed about that for 2 days. And now I'm like, maybe I could identify that to give the right medication, because my goal is to do the right thing for my patient, for that patient, to be able to give them the exact treatment that they need. And it's frustrating when you get in situations, which both of you have alluded to, where you know what the right answer is, but you're constrained and you can't give the right treatment that is evidence-based, that is safe, because somebody else who doesn't know how to, read literature, can't create guidelines without using ChatGPT. Those people are making the laws for us, and it's very frustrating.
I want to throw in like a couple of things for that. One is like, I love that what you harped on was you're like, okay, I had this situation, and what I decided to do from that was both learn from the experts and then educate myself in my own time. And like, I think I love that. And now you can disseminate that information to your residents, to your own practice, whatever it may be, to have a lot more, I would say, just like impact, just like scalable impact beyond that. And I think like what's cool about this specific organization, or like what our experiences have been, is that a lot of us have taken that time, both with the experience or learning from some of our colleagues, like the specialists with OB-GYN, or we've put ourselves in situations to learn this scope of care a little bit better. Like I did a few weeks with Planned Parenthood during residency, learning family planning, learning, MUAs, learning Med-ABs, learning all this sort of stuff so I could be comfortable with it from my own skill set, educate myself. And now it's like, how do you disseminate that? So I love that you said that. And then the other thing that I'm going to throw on there on top of that is, truthfully, yes, the laws are like absolutely one constricting factor, but I would also say that the culture of medicine is another equally constricting factor. Whether it's like we've decided this is not within our scope in our department, and like, yeah, New York State, we're backed here. Like you're in California too, like you're backed there, but it's also the cultural practice of both the physicians that you're working alongside, where they're like, I'm going to be comfortable learning something new, or like expanding my scope to meet my patient where they're at. I actually find that to be sometimes the most frustrating thing, because it's like right in front of me and it's so tangible, and it's like, just take the extra 7 seconds to either educate yourself or talk to the expert, or now all of us are creating protocols and pathways, etc. Just look that up, rather than just being like, not my job, someone else's problem.
Right. It's about responsibility, and it's about remembering that our patients are humans, and any of us could be in that situation, right, where we need care, and either our physicians aren't comfortable, don't want to learn it, or we're constrained. Sabena, you mentioned protocols. One of the things that I'm noticing that seems to be helpful is trying to make things easier to learn. If you boil me down to my most basic atoms with regards to medicine, I think the thing I like the most, and the thing that I think is the most important, is education. What have you guys been doing with regards to that? How are you able to take the knowledge that you've obtained with all of your training and be able to disseminate, try to get physicians who haven't had all the experiences that you've had to actually do the right thing?
Yeah. Morgan, I think you should answer that question with your protocol that you just launched.
Oh boy, such a huge question. I mean, Jailyn, I couldn't agree more. Education is it. It's the answer. It's always been the answer. It will continue to be the answer. I'm biased, just like Sabena alluded to. We both had careers prior to going into medicine, and I was a first grade teacher. I did Teach for America, and I often, when I'm working with colleagues, residents, all these things, I often envision my class of 35 6-year-olds in Baltimore City, and I realize that at the end of the day, we're kind of all first graders at heart. I happen to think it's like the best age, but I'm also biased as a pediatrician. But yeah, I think we have to make information manageable, and especially for the ED doc, right? And we hear this, and I totally agree. Every day we're being asked to do more with less. And I'm sympathetic to that statement, and I totally understand. Especially here in New York City, volumes are going up. Patients are getting sicker, we're getting less and less resources, and asking our colleagues to do yet another thing is overwhelming and time consuming. And I appreciate the fatigue and the burden and the burnout that we're all experiencing. But with that said, there's hope, right? Because emergency medicine has always met the challenge. I think that's one of the things that attracted me to it. You asked this previously and I didn't quite answer it, and then we'll get to our pathways. But what attracted me to emergency medicine, especially coming from a peds residency, I mean, yeah, sure, the procedures are sexy and it's a little bit cowboy medicine. And would I be remiss to say I didn't watch every single episode of ER growing up? Of course. But, still waiting for George Clooney to walk through the door.
Yeah.
But I think that what gives me hope in a time of very little hope is that we as emergency medicine providers go to work every single day to treat the patient in front of us. And we do it to the best of our ability day in and day out. It's like, sometimes I just want to say, bring it on. Like, what else are you going to throw at us? We'll rise. We'll meet the challenge. It's like my first graders in Baltimore. I mean, these kids had nothing. And yet they just surpassed their peers in learning to read because they had the motivation and the desire to do it. So with that said, I really believe that if we continue to hold ourselves, our colleagues, and our trainees to a really high level, to hold that to that level, they'll meet it. And I think that brings us to our pathways. So again, we're busy. I get it. And we also can't be expected to remember everything, right? There's just certain things that we look up every time, and we should, especially having very little OB training in pediatrics. I mean, that's just not something that you get, and especially in PEM fellowship, like we don't do that. So when people ask me for the doses of OCPs and things like that, I have to look it up. I don't know. So me and my team at Sinai created an algorithm to prescribe OCPs at ED discharge. This sounds, I don't know, like, duh, obviously we should be doing this, but we weren't. And so we created this pathway to make it as simple and as user-friendly as possible. It is a one-pager. You follow the algorithm, and there's two options. There's a combined OCP and a progestin only. We worked tirelessly with our OB/GYN colleagues to pick medications that were readily available, covered by most insurances, and we did spot checks at the pharmacy around our hospital to make sure that patients could get them, and to make sure that the contraindications were accurate. And we got it approved by the various committees at Sinai, and it's now available in Epic. So there's a hyperlink, it's right there. And the most exciting part has been when I get text messages randomly during the day from residents saying, I prescribed an OCP today, or I referred a patient to adolescent. And I feel like, despite all the negativity and all the gloom and all the uncertainty, when I get a text message at, 9 p.m. on a Friday from a resident saying that they prescribed an OCP and provided follow-up care for potentially LARC or counseling or whomever to a patient, it's like, this is why we do this. This is why we spent, decades doing this, and then being able to collaborate. So Sabena and I were, met not long ago and have been working together now. And when she said, hey, can you send me your pathway? I want to do something at my institution. And then to see her take that pathway and then add it and grow it and incorporate her residents in that work has been really inspiring.
I know that LARC isn't an offshoot of LARPing, which I haven't LARPed yet. I want to. I like costumes. Halloween is my favorite holiday, naturally. But sorry, what is a LARC?
Yes, so LARC is long-acting reversible contraception. So the two main categories for this are IUDs or intrauterine devices. Like Mirena and things like that are kind of common names. And then the other option is the Implanon, which is the insert in the forearm of patients. The brand name that people tend to know is like a Nexplanon.
Mm-hmm.
So those in our institution currently are not available in the ER. They're of course available outpatient. We're very fortunate at Sinai to have a very robust adolescent medicine clinic, complex family planning. So those things are available in our institution, just not in the emergency room. But we are working towards making those more readily available for patients who want them.
Now, both of you have mentioned that you've worked with pharmacies, you've worked with OB physicians. Now, in practice, I feel like, and this is me, I wish that I would have done more reproductive health training in residency and in fellowship. In fact, in med school, I'm very kind of open about this when I'm talking to medical students about how I chose emergency medicine. My favorite rotation in medical school by far was my OB rotation. I had such an amazing time. But then I also loved inpatient psychiatry. I also loved critical care. I also loved surgery. I truly loved surgery. I was like, I don't think I can be in an OR for that long, but I actually picked emergency medicine because I enjoyed everything, right? But what I liked was OB. Now, with that kind of framework, my area of expertise, as far as my training, is ultrasound. And when I'm creating protocols, when I'm looking at the data, especially if we don't have a lot in emergency medicine, what I do is I look at the specialty who typically owns it. I look at their literature and I talk with them. So for instance, I love critical care echo. And so I look at cardiology literature on exactly what do they know, and then what do I think would transfer well to emergency medicine. I've done the same thing with nerve blocks. I do a lot of nerve blocks because the sedation just takes too long. So, and I like nerve blocks. And so I looked at anesthesia's literature for that. And I've spoken with anesthesiologists about how they do their nerve blocks. And they're not exactly the same, right? Because they're doing it for surgeries. I'm doing it so that I can reduce a shoulder. How has your experience been trying to collaborate with these other specialties and then using that as almost legitimacy for when you're presenting it to, let's say, your chair in the emergency department?
I think making friends interdisciplinary is important. And I would say those conversations are twofold. One is we know our expertise in that we know exactly the setting that we practice in a way that no specialist can tell us. We know exactly how things go when we're counseling a patient in the emergency department, the vulnerability at discharge, whether or not they're likely to follow up, you know that space. So I would say have some confidence in that. And there's a reason that we're asking to partner, and there's a reason that we're looking at this space in general is because we have felt for a long time that our patients' needs are not being met with respect to sexual reproductive health care. So I would say stand on that ground with confidence, because there is a chance that you might be met with great, just have them follow up outpatient. We're more than happy to see them, put them through the patient navigator, protocol, et cetera, et cetera. But no, we need to do better. I want to start them on something today, or I want to at least have a plan in place where I've started the counseling. Maybe I didn't start them on the medication. The seeds have been planted so that they're more likely to follow up. So I'd say that is a really, really important leg to stand on. And then the second part being especially when working, with our OB-GYN colleagues, is you use them. They're knowledgeable resources. They know this space really, really well. And so, when we were making our own pathway for contraception, I was which OCP do you prefer? What do you like best? What do you find patients are not, concerned about, both the price or the adverse effects from as often? What's your favorite? I'll build that in. And then ours chose, a low estrogen, and we're sounds great. That'll be our preferred OCP. Even though I was thinking about something else, you know better than I do in this. Great. Now it's simplified. We've become partners on this. We're both bought into the same protocol equally. And we can just kind of be partners from there. And then the last one being that you were kind of talking about our relationship with pharmacy. I think that's critical because you need to know a couple different things. One is like what is available in your actual ED Pyxis / the hospital pharmacy, because that's going to inform what you're able to dispense. So for example, Plan B is an over-the-counter medication, but Ella is not. And we know that the effective length for Ella is longer lasting than just specifically for Plan B. So great, maybe you have a patient who is eligible for emergency contraception, which is actually part of this pathway where we're trying to remind people, like, offer emergency contraception if someone's had unprotected intercourse within 120 hours. Like, just ask. So if it's available, great, you can just dispense in the ED itself. Ours is available in our Pyxis. I know that because I've asked, and now we just dispense it when a patient wants it. And then you can do that even for Depo. If you have Depo, like the actual shot available, you can start it in the ED itself. So you know what's available to you in-house. Also, like with respect to pharmacy, most EDs are going to have a preferred pharmacy, whether that's in the same building or it's across the street or whatever it may be. I think figuring out what exactly do they have available as well. I mean, we have lists available that, like, we had pharmacy fill out, so we knew exactly, like, what do we have in our Pyxis, what exactly do we have at our preferred pharmacy, so that, like, again, we could make that protocol based off of the actual institutional availability that we had on hand. So, like, actually a really good example for that is we have been trying to get or encourage providers to do 12 months specifically, 12 to 13 months of medication dispensing for if you're going to be initiating contraception, just offer them refills. So for example, like if someone was like, oh, I think that the best option for me, since I'm not good about taking daily pills, I think a shot might just be the best way for me to go right now. LARC doesn't seem like the right option for me, is you can start them on the Depo shot. And the really cool thing is that our pharmacy also has a subcutaneous formulation so that the patient can self-administer it Q3 months at home. So like now I know that because I made friends with pharmacy. I have this shared document that they can see, they can update. They actually were the ones who filled out all the information. And it's informing our protocols, our practices, so that we can just all be bought in together. But I just want to say, like, don't let someone or any specialty, even though they really care about this patient population, say that this is not something that's needed in the emergency department space. There's a reason that this organization exists. There's a reason that Feminine has made it one of their missions to improve SRH care. There's a reason that Access Bridge exists. There's a reason that the three of us are having this conversation right now. It's because we haven't been doing a good enough job. So don't let anyone tell you otherwise.
That's so powerful. Now, let's say, as we wrap up, let's say that there's somebody that you know in a different hospital, different system, and they are like me. They didn't really have, official training in reproductive health care, but they want to start. Let's say there's nobody else in their hospital that is interested in this. What is a first actionable step that would help them along that pathway?
Oh boy, absolutely. First of all, yes, do the things, have the dream, set the goals. I would say you just need one ally. And that can be me, that can be Sabena, that can be someone at your local institution. You just need one person to talk to, one person to start the conversation with. And again, what we're trying to do with these protocols, and not just us, but all these organizations that Sabena mentioned, is we're trying to prevent folks from reinventing the wheel. We want to take the legwork and the struggle out of it as much as we can, and we want to promote these pathways. So connect with someone, and then I would say find an administrator at your hospital who can be an ally. I am very fortunate to work at Sinai and have some wonderful mentors and leaderships in the administration operational space that have said to me, this is a great idea, go for it and report back. And all you need is that green light to just make those friends, make those connections, and don't take no for an answer. The answer is never no. Mm-hmm. It's how can I make this work? Or what can when I started, I wanted to start with Nexplanons in the ER. That's where I started. And then I very quickly realized that maybe I needed to scale down just a little bit in order to make those friends, make those connections, and then we were able to get this OCP work off the ground. Because of the success of the OCP work, I've been able to launch into other projects, start an elective for my residents, redesign some of the OBGYN curriculum for our EM residents. So it's been a launching point. All in the while, the LARC is still happening in the background. So I would say to that person, especially if they are in a more restrictive state or place, to not be discouraged, because you have friends. And we're all here to help and to continue to push this work
Yeah,
forward.
I'm going to add just a little bit to that. Like specifically, I would also say like the two places that I think are just amazing. I mean, obviously biased because I'm saying this as a part of Feminem, but I would actually say go to the resources tab because it does collect a lot of different informational guidelines from a few different organizations. There's really good videos on there, and then figure out like what is it's kind of like what Morgan was saying, like what exactly do you want to make your mission statement. There's a lot. Like, are you finding that ectopic care is underperforming from what you think should be standard of care at your hospital? Are you finding that you really think that contraception could have a huge footprint if you improve those pathways? Are you trying to do medication abortion management in the emergency department? Are you hoping to improve early pregnancy loss management in the emergency department? Like, there's a lot baked in there, and trying to tackle it all at once, I have learned in the past year of like, oh my gosh, we're going to do everything. It's just not going to happen. Yep. And so giving yourself, I guess, a little bit of that permission to feel like, okay, I'm going to pick one specific area, try to figure out like, what is a process that I need to put into place in order to actually get this implemented, learn from that pathway, and then you can continue to scale from there. It's okay, like if your V1 version is going to be different from your V2 version, like maybe V1 is specifically if you're trying to do medication abortion, like MIFI, meso, dispensing in your emergency department. Maybe V1 is you do it through an OB-GYN consult and they dispense the medications. But V2 is we have a little bit more ownership over that and then we start doing the dispensing. Whatever it may be, it's okay if it's a moving target over time. Any little beginnings that you have is amazing. And as Morgan said as well, like there are states that are going to be a little bit different based off of like what exactly the legality of certain things are. So like how restrictive are they specifically with mifepristone access? And I think like you're going to obviously want to / need to adapt to that setting. So we have a state-based cohort that's in Georgia, for example, where they're like, okay, I think chasing medication abortion management through our emergency department doesn't sound like the right project right now, given the fact that, you know, we have a 6-week heartbeat bill here. And like, yes, it would be incredibly important to catch patients a little bit earlier, but what if, you know, every single time we have a UTI, we have an STI, we have pelvic pain that hits our fast track, what if we start to have some of those contraceptive conversations there? And like that's our V1, that's where we start, and like that's kind of where some of their focus areas have been. And so I think like, yay, amazing, that sounds amazing. And so like that's kind of like what their beginning starter phase has been like. So in summary, I would say look at some of the resources that exist and then figure out what your specific mission statement is going to be. And then thirdly is like figure out just like what's a bare bones tactical next step that you can take from there, and like what's the bare bones project that you can make out of that, and give yourself permission that like it can expand down the line, but it does not have to be your final stage in the beginning.
Morgan, Sabena, thank you so much for taking time out of your busy schedule. We're all busy, right? We're all like attendings, we all work. And then we have our regular lives as well. And then this is extra, and it doesn't mean that it's any more or less important, but I very much appreciate the time and the education.
Thank you. Thank you for this opportunity to share our stories, to share why we love this work. And I love this space, and I love every person I've met through it too.
Same.
It's been such a privilege. Yeah, it's been just such a privilege to speak with both of you and to be connected with all the people in this space. Like I said, there is light in the darkness. So thank you for being a part of that.
That's it for this week's episode of the Feminem podcast. A huge thank you to Dr. Morgan Bowling and Dr. Sabena Vaswani for sharing their experiences and insights on expanding access to reproductive health in emergency medicine. If this conversation has inspired you, start small. Find allies, explore your local regulations, and take that first step towards building reproductive health pathways in your emergency department. You can find more resources, stories, and upcoming episodes at feminem.org or wherever you listen to podcasts. And we have a new Substack, so definitely check that one out. My name is Jailyn Avila, and thank you for listening and everything that you do to advance equity and compassion in emergency medicine.